cardiology practices. Thank you for spending some time with us this afternoon. Let me give you just a quick overview of what we hope to accomplish in the next 45 minutes. We're going to start with some general background information on ICD-10. This is not going to be your 100 level course. We're going to move through this information quickly because most people by now know what ICD-10 is. We're going to take a bit of a different approach here and look at what the government has done that makes ICD-10 difficult. What makes it uniquely difficult here in the United States? Because there's some things that we're doing differently than a lot of the other World Health Organization countries who've already moved forward with ICD-10. I'm also going to share with you some of the mistakes we've seen practices make. Many of you may be behind in your ICD-10 planning. Many of you may be trying to catch up over the summer. If I can share some of the mistakes we've seen other cardiology groups make, maybe you won't repeat that same mistake. And then I also want to share with you, debunk some of the myths concerning ICD-10. There's a lot of bad information. There's a lot of misinformation out there about ICD-10. And a lot of it causes practices to freeze up. You know, it's analysis paralysis. It seems too difficult to move forward successfully. So you close your eyes and hope it gets delayed again. So we're going to try to debunk some of those myths. Then we're going to jump in and help you understand how to look at the impact to your practice, to your providers. How do you understand that? How do you digest that? Which parts are going to be easy? Which parts are going to be difficult? We'll help you get very detailed there. And then a couple of themes that you'll hear throughout our time today. First and foremost is physician productivity. If our doctors cannot continue to see and take care of patients, if our doctors are not generating revenue for the practice, if our doctors aren't happy, nobody else in the practice is doing those things. Nobody else in the practice is generating revenue. Nobody else in the practice is taking care of patients. We have to make sure we protect their time. At the same time, you have to balance that with the very real need that is we have to get this coded correctly. We have to get our claims paid. But we don't want to turn our doctors into coders. So we're going to talk through that. You'll hear that as a theme throughout our time today. Another theme that you'll hear throughout today is that we're going to talk about the difference between ICD-10 compliance and ICD-10 productivity. A lot of people mistake ICD-10 for a pass-fail test in college. You want to do just enough to pass, but that's really it. Yes, ICD-10 is a compliance issue, but it's not a pass-fail test. There will be some practices who are very well prepared. There will be some practices who are not. You want to make sure you're not just aiming at ICD-10 compliance, but that you're productive, your doctors are productive, your billing staff is productive, your revenue cycle is productive, that you've analyzed your workflow, and that you're well prepared for the changes that are coming. I will leave time for questions and answers at the end like we talked about before. Use the questions panel in GoToWebinar, and I'll try to answer as many of those as I can and make sure we still end on time. So let's jump in. What makes ICD-10 hard? What makes it uniquely difficult here in the United States? The first thing is that it's a one-day conversion. Now, I'm sure everybody's familiar with this, that the magic day for ICD-10 is Thursday, October the 1st. It's a one-day conversion. That means there's no grace period on the back end, but there's also no transition period on the front end. What that means is on Wednesday, September 30th, you have to use ICD-9 codes. You cannot convert to ICD-10 early. But it doesn't get phased in. There's no grace period on the back end. There's no forgiveness period. You have to get that done, and you have to get it done correctly on that Thursday, or claims don't get paid. Now, you could say that's very similar to what a lot of other countries did. A lot of countries had a one-day conversion for ICD-10. And that may be true, but what makes ours uniquely difficult is the uncertainty surrounding this ICD-10 conversion date. This isn't our first ICD-10 conversion date. It's actually been delayed 3 times already. twice by CMS, and then most recently last spring by Congress. ICD-10 has been delayed, and you've got a lot of people that are waiting and hoping that it gets delayed again. It's a lot like the story of the boy who cried wolf. Everybody probably remembers this from their childhood. When the wolf eventually came, yes, the boy had lost his credibility, but who paid the ultimate price? It was the sheep and the owners of the sheep that suffered. When ICD-10 arrives, it will be the practices that are unprepared. It'll be their providers, their employees, ultimately their patients who suffer as a result. And our government has done us a great disservice in this regard by not providing clarity of that date. That makes it very difficult. Trying to get colleagues, trying to get providers, trying to get staff on board to invest the time and resources necessary to be prepared when they're thinking or hoping that it might get delayed again. That's a challenge that most of you probably face. The next thing that makes it uniquely difficult here in the United States is that it's a large change for physicians. Right? Again, you could say, now wait a minute, ICD-10 was a change for doctors in Canada and Australia and France and England when they moved to ICD-10 too. And that's true. But what's different about our providers, what makes them unique, is our doctors aren't government employees. They're small business owners. They can't slow down. In our fee-for-service world, they're paid based on their productivity. They cannot slow down to deal with an unfunded mandate like ICD-10. And what makes it even more challenging is it's not something that they're interested in. They didn't go to medical school to be a coder. So it makes it very challenging for administrators or billing managers or ICD-10 project managers. How do you protect your doctor's time when they aren't interested in spending the time up front to learn the new code set? How do I train them on the fly and still have it be productive for them? We're going to talk about some ideas of how to do that. But it's a significant challenge. And I think what makes ICD-10 most difficult in the United States is we've had a lot of change for the past 6 or 7 years. Right? A lot of government intervention with e-prescribing and PQRS and meaningful use. And all of those programs were optional. They had incentive bonus payments that you could earn. They were Medicare, Medicaid specific, and they were gradual. And ICD-10 is none of those. ICD-10 has so much at stake because it's a one-day conversion. It's not just Medicare and Medicaid, it's all of your payers. There's no incentive dollar to earn. It is no carrot and all stick. And if you're not approaching ICD-10 correctly, the penalty can be quite severe. And it's not just about getting claims out the door. It's not just having ICD-10 codes on a claim form. You've got to have them coded correctly. Just like you do in ICD-9. You've got to jump through the hoops and hurdles that the payers put out there for you. And we're going to talk about that as well. So ICD-10 is a significant challenge for practices, absolutely. But some practices make it harder on themselves than it has to be. A lot of practices make some common mistakes, and I wanted to share some of those with you in hopes that you might not make the same mistake. The first one is the assumption that ICD-10 is just a coding project. Right? This one typically goes something like this. You ask the doctor, hey, what are you guys doing about ICD-10? Oh, we've got a great coder. You know, she's responsible for all things ICD-10. She's going to boot camps. We're going to be fine. Well, those are great things for your coding team, your coder, your billers to do. And you want to make sure that they get ready, that they get certified, that they get trained. Because it is a big change for them, but that is only part of a successful strategy. Other people make a similar mistake. Oh yeah, well we've got a great EHR and we're going to be on the right version, so everything's going to be okay. Our vendor told us there's nothing to worry about. Right? Again, That is a great part of a successful strategy. Ask all your trading partners, what are you doing to be ready for ICD-10? What version do I need to be on? Is there any cost associated with that? All of those are great things to have on your checklist. But we've all learned the lesson. It's not enough just to be on a certain version of the software. You have to understand how that works. What steps do your users have to take? Are your doctors willing to do that? What about your coders? How long will it take them? How much training will they need? What about the workflow? Does it fit into your process? Or will there be workflow modifications that you have to make? You have to go beyond just the surface level and understand how it's going to work and how that's going to impact your doctor's time, how that's going to impact your revenue cycle. That's why we recommend viewing ICD-10 as a strategic initiative. That means getting your management team on board, getting your doctors on board. Now, they don't have to be in on every meeting, but they do need to understand what's at stake and what strategies you're putting in place to mitigate those risks. And again, the big risk that we recommend focusing on is, number one, doctor productivity. Absolutely have to do that. But number two is revenue cycle efficiency. And when I say revenue cycle efficiency, what I mean by that is how many people, how many billing staff, how many hours do they spend to collect your cash flow, and at what rate? Because if you have to hire more people, or if your same employees collect less cash flow, or if it takes them longer to do that, those are bad outcomes that will negatively impact your cash flow. And we want to put processes in place to protect against that. Now, let me share a study with you. This was done by the advisory board trying to put some numbers to some of these concerns. They looked at what happened after ICD-10 implementation in Canada. What were the post-go-live costs? What were the ongoing costs? Right? A lot of people miss this. Look what they put front and center. Physician productivity decline of 10 to 20%. That is unacceptable. In a busy cardiology practice, in a fee-for-service world, that cannot happen. If you want to get underneath those numbers and understand a bit more what happened there, you had coders, you had billers going back to the provider, saying, I need you to be more specific here. Can you tell me more about the disease stage? Can you tell me more about the etiology? Can you tell me more about the onset? And answering those back and forth questions took, on average, 45 to 90 minutes per doctor per day. Again, that is entirely unacceptable. Even if you cut that in half, where are your doctors going to find that kind of time? They can't see fewer patients, and it's unfair to ask them to answer those questions at the end of the day rather than spending that time with their family. That's why we put that as the most important thing your practice can do to prepare for ICD-10. But I also want to talk about the coder productivity and the rework productivity, which you see on the left and right of this slide. Coder productivity will decline significantly in the first year. But you'll see as they get more familiar with that, as they get up the learning curve, they will get some of that back. They'll get some of that productivity back, but they're never going to get back to current levels. And that's not their fault. It's just because ICD-10 is more difficult. ICD-10 is more complicated. And again, we've got to think about what can you do to make those employees more productive so I don't have to have people working overtime, so that I don't have to hire additional employees to deal with ICD-10. What can I do to get out ahead of this? And same thing on the rework productivity. You see that 10 to 25% decrease in productivity there is a result of an increase in adjustments, denials, inquiries coming back from the payers. The best place to look for what that might look like for you is look at the early end-to-end testing results that Medicare did. Denial rates were doubling and tripling as a result of ICD-10. So if you have a denial rate of between 2 and 3% today, that may be 4 or 9% in ICD-10. Not a catastrophic increase, but a significant increase nonetheless. You cannot change your external payers. You cannot control that. What you can control is how well prepared you are. Get your denial rate as low as possible today so that you can, and you have a good process in place to respond to the changes that are coming so that you can be on the low end of that increase in the future. All right, now I don't want to be all doom and gloom because ICD-10 is not impossible. You can be successful, and it's not as bad as a lot of people make it out to be. You know, some of the scare tactics that we see people using, everybody always talks about how many new codes there are in ICD-10. You've probably seen something like this before. 69,000 codes in ICD-10 compared to only 16,000 in ICD-9. And that's true, but it's only a half-truth, because you don't use all of those codes today in ICD-9. And you won't use all of those codes in ICD-10 either. Most practices use less than 2% of the entire code set. We recommend focusing on the codes that you do use, that you will use, rather than spending time worrying about the codes that you'll never use. You know, which leads me into another point. You know, one of the famous targets that people who kind of dabble in ICD-10 like to talk about are some of the crazy new wacky codes in ICD-10, right? People like to use these as excuses as to how crazy and ridiculous ICD-10 is, that we'll never use it, right? It could never possibly work because of crazy codes like this. This is probably the most infamous ICD-10 code. V91.07XD, water skis on fire. And that's true, that's a valid ICD-10 code. But what most people don't tell you is that it's also a valid ICD-9 code, E837.4. Very, very similar code, and you never use it. You don't use it today, and you won't use it in ICD-10. Most of those crazy codes that people like to talk about already exist in ICD-9. They're E codes, what are external cause codes. And Medicare has actually already come out and said, if you are not using external cause codes today, you will not be required to use those in ICD-10. There's no new national mandate that requires the use of external cause codes. So let's not focus on those. They serve as a distraction. It paralyzes people. And it takes your attention away from some of the more silent killers. And I'm talking about unspecified codes. Most practices use unspecified codes today in ICD-9. They do it to save space on their super bill. They use it as a catch-all. They use it because that's the level of specificity their documentation allows. They use it to make the templates in their EHR easier. And all of those things are fine because there are no negative consequences to using unspecified codes in ICD-9. For the most part, they're payable diagnoses. But in ICD-10, there is significant risk to using unspecified codes. There's a short-term risk and there's a long-term risk. The short-term risk is that the claims will get denied. The claims will get denied. Now, that may or may not happen on day one. It may be 3 months in before you start seeing that. It may be 12 months in before you start seeing that for certain payers. But it will happen. The reason the payers want to move to ICD-10 is because they want the more detailed diagnosis information. They want the more granular diagnosis codes so that they can understand what's going on with their patient populations, so that they can ultimately reduce total healthcare expenditures. That's why they want the data. That's why they've advocated for ICD-10. That's why they've lobbied for ICD-10. That's why they've invested the dollars to change their adjudication processes and rewrite their systems. They want that data, and if the provider community doesn't give it to them, they're going to deny those claims. That's the short-term risk. The long-term risk is everybody knows the government is trying to transition away from fee-for-service, move us into a pay-for-performance, a pay-for-quality, a pay-for-outcomes model. And in that world, it is all about severity of the patient diagnosis, the acuity of the patient diagnosis, comparing the expected outcome to the actual outcome. And that's the concern. You need to use the more specific diagnosis codes in order to maintain and maximize your reimbursement in a pay-for-quality world. So that's the short-term risk and the long-term risk of using those unspecified codes when we move over to ICD-10. So where do we recommend starting? Don't worry about the codes you don't use. Let's focus on the codes that you do use. We've done this for all of our clients. We've looked at their ICD-9 codes and done what we call ICD-10 conversion analysis. We take the ICD-9 codes and we see what they convert to in ICD-10. Now you'll see for most practices it's between 200 and 300 codes in ICD-9 that they use. When you convert that into ICD-10, you'll see two things. Number one, you'll say, gosh, that's a big increase for everybody. Number two, you say, thank goodness I'm not in an orthopedic practice. They have by far the most difficult task ahead in their conversion to ICD-10. Now, we typically go a step further and say, okay, see that, but not all codes are converted equally. What does that look like? Some are more difficult than others. So we put them into three different risk categories: low risk, moderate risk, high risk. And let me explain what that means, what that looks like. The low risk codes, everybody loves those. Those are the ones that have one code in ICD-9, and they match up exactly to one code in ICD-10. All right, those are pretty easy. Unfortunately, for most practices in cardiology, that's somewhere between 45 and 50% of the codes that you use most frequently that fit into that category. The others fit into the moderate risk or into the high risk category. Moderate risk means there are between 2 and 10 ICD-10 codes for each individual ICD-9 code. So one code in ICD-9 turns in to 2, 3, 4, up to 10 codes in ICD-10. The high risk are those that have 11 or more choices in ICD-10. Okay. If you're interested in looking at this in greater detail, let me show you just a couple of examples. We do this, again, for our clients. We do this for anybody who attends one of our webinars. It's a free service that we offer. If you send us an Excel file with your ICD-9 codes in it, we'll send back the ICD-10 conversion analysis. It gives you the summary data up at the top, but then it also gives you the line-by-line detail so that you can see, CABG, one code in ICD-9, one code in ICD-10. Here's the new code. Here's the new description. Edema. Next one down, one code in ICD-9, 3 codes in ICD-10. Is it localized? Is it generalized? Is it unspecified? Right? And then you can see a high-risk example here, CHF. Got to be more specific in ICD-10 as far as the onset and the type of heart failure. I think this is a helpful thing to share with your staff, to share with your colleagues, to share with your providers. It does two things. Number one, it relieves some of the anxiety about ICD-10. Yes, it's going to be a significant increase, but it's not impossible. I don't see anything about being struck by a turtle or walking into a lamppost or any of those other crazy ICD-10 codes on here. The clinical concepts are familiar. But number two, it says, okay, the status quo probably won't work for us. We can't do things the same way when we have 800 codes as we did when I had 200. Okay? Another way to look at this, if you're a numbers person, if you're a data person, that's a really helpful place to start. If you're more of a visual learner, let me show you this way. And I'm going to pick on the American Academy of Family Practice for a second. because they put this on their website. It's an ICD-10 super bill that they recommend their members use. It has CPT codes on the front. It has diagnosis codes on the back. I'll use this as an example of how to think about ICD-10 compliance compared to ICD-10 productivity. It works great in ICD-9. You know, we did a survey last fall and found that 54% of practices are still using a paper encounter form, a paper super bill. But what does it look like in ICD-10? That's what really caught my attention. They have this published on their website. What, you want to see what it looks like? The front side looks the same, no changes to CPT codes. But the back side looks like this. It's 8 pages long. That's unacceptable. You cannot put that in a doctor's hands. It may be ICD-10 compliant, but it's not ICD-10 productive. You can't use an 8-page super bill. That causes a workflow nightmare. And you can't make the super bill 8 times as big either. You know, again, an ICD-10 compliant solution, but probably not productive. We have to think about the workflow. Now, many of you may be saying, well, we don't use a paper super bill today. That's fine. I'm using this as an example of how to think about these types of challenges. And many of you may not. Maybe you have doctors who write in a diagnosis description. Somebody codes it downstream. Maybe you have coders that are coding from the doctor's note. The doctor dictates, and the coder is going to code from that. Maybe you have doctors that are completing templates in their EHR. It's not just the codes that change. The descriptions change too. The concepts change. The documentation requirements change. If you've got a doctor who writes in CHF and somebody's going to try to code that downstream, that employee downstream is either going to have to use an unspecified code, which we already talked about why that's risky, or they're going to have to go back and ask the doctor to be more specific, which is right back to my 45 to 90 minute per doctor per day problem that we saw in Canada. You've got to think about the workflow. Got to think about how that works. And what makes this so successful today is the doctor's muscle memory. They know where the codes are on the page. They can fill it out with their eyes closed. So how are they going to handle this in ICD-10? When we talk to other cardiology practices, I've typically seen 3 different workflows that they're pursuing. The first one I see more in the hospital setting, more in health systems than I do in physician practices, but I do want to mention it. I can hire certified coders to do this work. The problem here is that they are expensive and that they are getting more expensive. And at the same time, they're getting less productive. That's a double whammy there. Most practices, if the economics don't work for you to do that today, they're not going to get any better when we transition to ICD-10. I want to mention that, but I see more practices do option number 2 or option number 3. Option number 2, easier said than done. Sometimes easy for me to say, maybe hard for you to do, but is get all of your doctors to do this correctly in the EHR. Now again, if you are struggling with that in ICD-9, if you're having pushback from your doctors, it's usually not because the doctors hate technology or the doctors just like being non-compliant. It's typically because they're worried about their productivity. Right? We've probably all been in meetings with physicians where they've been counting clicks. The problem is, again, that gets worse, not better in ICD-10. That's the struggle for the ICD-10 project manager. And this is where you start to have to get underneath the covers and ask your EHR vendor, how is it going to work? Because many of them are handling it through a code search process, which sounds like a great idea, right? Search is easy. It's just like Google, right? We've been trained to think that way. But it doesn't work the same way for diagnosis code search, and let me explain why. Here's how Google works. You type in a search query, you get the search results, and 99% of the time, the answer that you're looking for is at the top of the list. Right? That's why everybody fights to be at the top of Google's organic search results. It doesn't work that way searching for diagnosis codes. If you search for diabetes and you get 50 search results, it's like an old SAT test. You have to read through all of the available choices to choose the diagnosis code that's most accurate for that patient encounter. And it may or may not be at the top of the list. Many times, the unspecified ICD-10 codes are at the top of the list because the list is organized, sorted by diagnosis code. That's the problem with code search. A lot of people are going to get burned by that if they don't ask their vendor to show them. Show me how it works. Don't show me with the easy examples. Show me with my specific examples, the hard examples that my doctors are going to have to do every day. Now, I'm certainly biased, but I like the third option the best. It's an electronic superbill. Design it in a way to make it look like the paper superbill. Protects the doctor's muscle memory, makes it faster for them to learn and faster for them to use. At the same time, making sure that the billing team gets the right data that they need the very first time to get that claim paid. So let's take a look. I'll use this as an example to show you some of the low risk, moderate risk, high risk, because again, sometimes a picture is worth 1,000 words. This is Capture, electronic superbill to design to look just like the paper superbill does today. Customize that for each client. So I'm going to show you what that looks like and how it works. I'm going to show you one encounter in ICD-9. And then we'll turn around and do the exact same encounter, this time in ICD-10. Okay? Let's do ICD-9 first. Maybe I've got a level 3 office visit, right? And we also did a stress test and an EKG. Flip over to the back side. I've got my diagnosis codes. I'll do 3 of them. We'll do CABG and edema and CHF, right? Just like I showed you on the conversion analysis, right? Pretty fast, pretty simple in ICD-9. Now, let's do that exact same encounter this time in ICD-10. What I want you to think about is, pretend I'm one of your providers. I haven't come to any of your ICD-10 training classes. I'm walking in. It's Thursday morning, October the 1st. I'm going to see my first patient, and I'm going to try to do this. All right. Level 3 office visit, stress test, EKG. No change to the CPT codes, right? So far, so good. Let's look at the back side. Is the back 8 pages long? Does it list out 900 ICD-10 codes? No. It looks exactly the same. This is the magic of what you can do with an electronic superbill. Puts everything in the exact same place. So far, so good. Let's click on CABG. When I do that, what you'll see, this is the first change. It highlighted that in green instead of in yellow. It converted that into ICD-10 for me automatically. We love those low-risk codes. For most cardiology groups, it's somewhere between 45 to 50% of the codes that fit into that risk category. Let's look at something a bit more complicated like edema. When I click on edema, you'll see it cannot convert that for me automatically. It gives me the pop-up. It shows me my choices. So with one extra click, I can say that it's localized, closes the pop-up window for me automatically, puts in the new ICD-10 code, the new ICD-10 description. I'm done. Okay, so far so good. What about something that's more difficult like CHF? 15 choices here. When I click on the pop-up, you can see we don't list all of those out. You don't have to read through 15 different descriptions trying to understand how they differ from each other. We've organized this to where you have the type of heart failure, systolic, diastolic, combined across the horizontal axis, and you've got the onset, whether it's acute or chronic, or acute on chronic. on the vertical axis. So it allows me to quickly recognize what the choices are. I don't have multiple options to drill down, multiple pop-ups to select through. I don't have to read through a big long list. I can quickly say it's chronic diastolic congestive heart failure, and I'm done. Again, it puts in the code, it puts in the description. If you have doctors who are still dictating, a lot of them like to refer to the paper superbill to remember who they saw, what they did. They can do the same thing on the electronic superbill. A lot of our clients even have staff print those out for the provider so that they can dictate at the end of the day without coming back to their computer. Again, it's about making this easy for your doctor. Don't require a lot of ICD-10 training. Don't turn them into a coder. Don't slow them down, but make sure that you've got the data necessary to get the claims paid. Now, I've spent a lot of time talking about the provider. Let me spend just a few minutes talking about the billing team because it is going to be a big change for them as well. Right? It's a one-day conversion, but they're going to be dealing with ICD-10 and the changes related to ICD-10 for months and years to come. When you zoom out and think about the revenue cycle from a big picture, we get paid in our fee-for-service world based on CPT codes. Now, you do have to have a diagnosis code that makes it medically necessary. That's true in ICD-9. That's true in ICD-10. If only it were that simple. You still have to play that cat and mouse game with the insurance carriers, the hoops and hurdles that you have to jump through in order to get the claim paid correctly. And then to make it even more difficult, it doesn't work the same way for each payer. Blue Cross wants it one way. Medicare wants it another way. You've got to keep up with that. And you've been doing that for the past 30 years. You probably have people in your office who know the ins and outs of that cat and mouse game. And they keep up with the changes. But the volume of change is relatively small and relatively stable. And they've been doing it for a long time. Unfortunately, that head knowledge goes out the door overnight. You'll still have to go through the same process, but the details, the rules of the game will change. And not all payers are going to handle that the same way. Remember, the payers have never done this before either. They're going to be making adjustments. They're going to be making changes just like you are. And that means we will be in a very high change environment. Across payers and across time, the volume of change will be much higher than anything that we've seen in our careers. And what that means is we have to ask ourselves, on October 15th, on October 30th, when we start having changes, how are you going to manage that? What types of tools do you need to manage that? What types of processes do you need in place? You know, who's going to manage that process in your office? And maybe the scarier question to ask is, what happens if you don't manage that? Or if they don't do a good job managing that? For the billing team, for the coding team, ICD-10 is going to be a marathon, not a sprint. And what that means is if you're going to run a marathon in October, you need to start getting in shape for that now. You need to get out ahead of that. Anybody can do this. What we recommend for our clients is putting in a process called closed-loop denial prevention. Now, you could do this manually. It's obviously better if you have software tools that can help you do this. But what you're trying to do is say, okay, I recognize that I can't rid the world of denied claims. There are always going to be new denials. There are always going to be new policies from the payers. But here's what I can do. When I see a new denial, when I see a new policy come from the payer, I'm going to go back to the beginning. I'm going to figure out what went wrong and how I can make sure that that doesn't happen again. So I'm going to build in a new rule. That way, the next time the exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months, that rule is going to fire the exact same way for all of my employees. Whether it's my most senior certified coder or my newest billing clerk, they both have access to the same actionable information to make sure that that claim doesn't get denied again. That's closed loop denial prevention. That's what we want to do, and that's part of what makes the difference between ICD-10 compliance and ICD-10 productivity. Then this is the last slide, and then I'll try to answer as many questions as I can. Think about what you want your practice to look like. What do you want it to look like in your office in October, in November? What it will be like for your providers? What will it be like for your billing team? And what's the goal? Right? Is the goal compliance, or is the goal productivity? Compliance says, hey, we can submit claims that have ICD-10 codes on them. Right? That's kind of the bare minimum of what you can do there. Or do I need to make sure that my workflow is optimized for ICD-10, for my providers, for my billers? Are my doctors going to be staying late to answer coding questions? Or are we going to be able to protect their time, protect their productivity? Because that's what they want to be focused on. They want to be taking care of their patients. And that's what our patients expect as well. Our patients aren't thinking about ICD-10. They're not going to think that anything should be different on October 1st than it was the day before. They want the same high-quality service that you provide today. What about my billing team? Are they going to get the data that they need to get claims paid the first time? Or are they going to be working nights and weekends trying to get those out the door? Are they going to have the tools that they need to keep up with changes from the payers? Or are we going to have to outsource some of that work or hire additional resources to keep up with that? And the problem with that, the problem with outsourcing that, or the problem with hiring additional employees is that there's no additional revenue for ICD-10. It's an unfunded mandate. There's no additional revenue. That means any additional costs are going to come straight off the bottom line. That'll be practice profitability that suffers. And a lot of people are going to be surprised by this. They're not looking ahead. They're not paying attention. And they're going to see it at the end of the year. Or they'll see it next year when 2016 looks worse than 2015. It doesn't have to be that way. You can get out ahead of this. You can be more productive. You can be more profitable. But you've got to make sure that you plan ahead. Now, I know I went through a lot of information. I hope that this was helpful for you. Let me stop there, and I'll try to answer as many of the questions that you have as possible.